Temporomandibular joint. Today's topic is this is the joint formed between the temporal bone and the mandibular bone. Number 4. Vinay Marvi, Professor Anatomy. Introduction. Let's see. You see clearly this is the mandible. This is the mandible bone and this is the temporal bone. You can see external acoustic meatus, temporal fossa. Temporomandibular joint, in short, is also called as TMJ. It is a synovial joint that permits the mandible to as a unit with the two functional patterns, that is gliding and hinge movement. Gliding and the hinge movement. So we'll see what are the movements that are possible. So if you try to move the jaw, lower jaw anteriorly, so that movement is called as protrusion. If you are bringing it back, it is called retraction. The mandible is elevated, it is called as elevation of mandible. If you are opening your mouth, then that movement is depression of mandible. So there are two primary movements that are possible in TMJ. That is number 1, transitory movement in the superior part of the joint as the disc and the condyle traverse anterior along the inclines of the anterior tubercle to provide an anterior and inferior movement of mandible. So this movement is called as transitory movement. Next, other movement is hinge movement. In the inferior portion of the joint, between the head of condyles and the lower surface of disc, it permits opening of the mandible. So this movement is called as hinge movement, that is opening the mouth and closing the mouth. So that happens. So whenever the mouth is closed, this is the head of mandible, this is the articular disc that you can see, and this is mandibular fossa. Head of mandible, articular disc and mandibular fossa. So lateral pterygoid helps in depression of mandible. This muscle is lateral pterygoid. So this moves, and there is also forward movement of disc and the mandible at the upper joint, or the upper compartment. So this articular disc divides the joint cavity into upper joint cavity and a lower joint cavity. We'll see the 4 anatomical parts concerned with mandibular articulation. Number 1, mandibular condyle. So this is the cut section where you can see mandibular condyle, and this is the mandibular fossa and the articular eminence. This is articular eminence. This is the articular disc and the articular capsule. The articular capsule. This articular capsule. These are the 4 anatomical parts concerned with mandibular articulation. The mandibular condyle articulates with the glenoid fossa and articular eminence of the temporal bone. They articulate with glenoid fossa, also called as mandibular fossa, along with the articular eminence. An article disc separates the articular surface so that it has 2 cavities. You can see the one which is in blue color, that is sky blue color. So this is called articular disc. This divides the joint cavity into upper compartment. It is upper joint cavity and a below compartment or inferior compartment or lower joint cavity. So the upper compartment is between the disc and the temporal bone. So this full part. The lower joint cavity or lower compartment is between the condyles and the disc. The joint capsule is attached below to the articular margin, the head of the condyle. Here it is attached to the head of the condyle and above to the margins of glenoid fossa and articular eminence. The inner aspect of capsule is lined by synovial membrane. The inner aspect of synovial membrane. At the sides, the capsule is strengthened by collateral ligaments, of which lateral temporomandibular ligament is the strongest. The lateral temporomandibular ligament is attached above to the zygomatic or the zygoma, and below it is attached to lateral surface of posterior border of neck of mandible. So this is lateral temporomandibular ligament. There are two accessory ligaments associated with TMG. Number one, stylomandibular ligament, so which extends from styloid process and the posterior border of ramus of mandible. So this is stylomandibular ligament. Stylo means one is attached to styloid process. Mandible means it is attached to posterior border of ramus of mandible. Next is spinomandibular ligament. It extends from spine of sphenoid and lingula of mandible. So here you get spine sphenoid on one end, other end it is attached to lingula of mandible. These ligaments limit the range of movement of condyle, preventing it from coming in contact with the tympanic plate behind and crossing behind the articular eminence in front. Mandibular condyle. Mandibular condyle. It is the articulating surface of mandible. It is convex in all directions, but wider lateromedially than antero-posteriorly. It has lateral and medial poles. The medial pole is directed more posteriorly. The long axis of two poles deviated posteriorly and meets at the anterior border of the foramen magnum. The mandibular fossa are the articular eminence. The glenoid fossa is also called as mandibular fossa. Posteriorly, it is limited by squamosal fissure. It's a fissure. Anteriorly, it is bounded by articular eminence. So, articular eminence, and this is the fissure that you can see, squamotympanic fissure. The roof is made up of thin layer of compact bone separating the middle cranial fossa. This is the roof of mandibular fossa. Articular eminence is mainly made up of spongy bone covered by thin layer of compact bone. It consists of commonly seen in the chondroid tissues commonly seen in the eminence. And the fibrous layer covering the articular surface of temporal bone over the eminence is arranged in three zones: inner, outer, and intermediate zones. Next is the menisci, or also called as intra-articular disc. Fibrous, avascular, non-inverted plate. Shape is oval, biconcave in sagittal section. It is thin in central part and thick in the posterior borders. Attachment. Medial and lateral poles are surrounded by medial and lateral ligaments. They divide the joint into upper compartment and lower compartment. Anterior border divides into upper and lower lamella that run forward. Upper lamella fused with anterior slope of articular eminence. The posterior border divides into upper and lower lamellae. It is fibrous. The upper lamella is fibrous and elastic, fuses with capsule of inserted into squamotympanic fissure. So this is the upper ramus. The inferior ramus or the lower ramus is non-elastic, attaches to body of the condyle. The whole of TMD is enclosed by fibrous capsule. It is lined by fibrous synovial membrane. Laterally, the capsule is reinforced by temporomandibular ligament. The synovial fluid is present within the joint cavity, which is clear, straw colored, viscous fluid. Hyaluronic acid is highly viscous. It acts as a lubricant and also supplies nutrition to the temporomandibular joint. Now we'll go to the blood supply. There are four arteries which go and supply the joint. One, superficial temporal artery, deep auricular artery, anterior tympanic artery, ascending pharyngeal arteries. These are the four arteries which go and supply the temporomandibular joint. All these four branches approach the joint and penetrate the capsule before supplying the joint cavity joint. Next we'll go to nerve supply of the TMJ. All are branches from mandibular nerve. Number one, auriculotemporal nerve, mesenteric nerve, deep temporal nerves. They all supply the surface of the head, fossa, capsule and part of the disc. Now we see what are the age changes. So in case of children, how the joint will be there, and in case as the age progresses, what happens to the joint. The condyles become more flattened, the fibrous capsule becomes thicker, osteoporosis occurs in the bone. The disc becomes thinner, shows hyalinization. The synovial fold or the synovial fold are fibrotic. The blood vessels is thickened. Changes could lead to dysfunction in old age, impairment of movement, decrease in secretion of synovial fluids.